Okay. Thank you for inviting me here to speak today on behalf of Ernst & Young. I'm going to be focusing today on public-private partnerships, which have been a major focal point for our business for quite some time. I'm going to be using international examples to then contextualize and talk about the Greek situation and whether or not there'll be applicability in Greece, and specifically focus on healthcare and life sciences. And just to kind of outline my assumptions, when talking about public entities, we're going to be talking about publicly funded healthcare providers and payers funding these. And when talking about private entities, we're going to be talking specifically about life science companies such as pharma companies, biotech, and medtech. Before going too much into the detail of public-private partnerships and what they are, perhaps we can talk a little bit first about what the prohibitive factors are for public-private interactions. In different sectors, there's probably, it's fair to say that there's probably been a lot more public-private working between the two sectors as opposed to within healthcare and life sciences. Examples of this, for example, are roads, prisons, and schools. If we think specifically about healthcare as a public good, there are obviously additional complexities to be considered. And I just wanted to highlight, we've heard a lot about this over the last couple of days, so I don't want to spend too much time on it, but the massive challenge that we have in all healthcare systems, this is obviously not unique to Greece, around resource scarcity and the frustration that this creates on both sides of the coin. So for public providers, even if they want to purchase innovative health technologies and treat more patients, they're dealing with fixed budgets, in fact decreasing budgets in many cases, and we've heard a lot about that. So in terms of the moving forward, we see a condition of increasing resource scarcity in most healthcare systems, not only Greece. And three inconvenient truths that really need to be considered are, one, even if we're affording the highest priority to innovative health technologies, they'll never keep up with patient demands. Obviously, it's inelastic, public good. Secondly, there probably won't be increases in healthcare budgets. So the question is, what do we do moving forward? And thirdly, it's probably fair to say that in most healthcare systems, there's a shift away from hospital-based models, which then questions how we should be approaching the market, both from a private perspective and a public perspective. On the other side of the coin, this is a more common prohibitive factor, and that is the distrust for the pharmaceutical industry or for private entities, given specific instances that have happened in the past. So things like excessive lobbying, payments to physicians, lack of transparency around clinical trials data, and indeed the costs related to that. And obviously the pharmaceutical industry and private entities are trying to do a lot to make up for this. Here is an example of the evolution of market access strategies for lots of different products, and this is probably representative of the last 5 to 10 years. So we've heard a lot over the last couple of days around basic measures such as discounts, rebates, and clawbacks. But then if we look at other more innovative market access strategies such as expansion of insurance coverage or use of real-world evidence, which I'll go on to talk about, these are innovative, but they don't actually mean significant increases in patient access and or health improvement. So this, I think, is very representative of the issue that we have between public and private entities in healthcare and life sciences, and the fact that we really need to re-examine new and innovative models, potentially around risk transfer. In terms of enablers, the biggest focal point for us is probably data, and specifically real-world data. And for those not familiar, real-world data is essentially anything outside of controlled clinical environments, i.e. randomized controlled trials. And pharma companies generally use RCT data to substantiate value. And there are a number of different blockages in the value chain for data. Therefore, we're seeing a big opportunity in most healthcare systems on both sides, given the amount of real-world data that payers and providers and patients effectively sit on. There are obviously major issues around privacy of data, quality, quantity, and access, and I'll go on to talk about these. But generally, across these four groups, we're seeing an evolution, but at different rates in different markets. Secondly, there's an increasing precedent for risk sharing in a number of different forms. PPPs, which we're going to talk about, are quite complex compared to some of these, but some of the different market access strategies that I defined before do use some manner of risk sharing. But generally, we're seeing an openness to not being on different sides of the table and actually, I guess, an acceptance that public entities maybe aren't best at doing particular services and vice versa on the private side. And this, finally, is an evolution of our services. So probably 5 to 10 years ago, we were focused very much on formulation changes and value dossiers. And now we're focused very much on data, health, clinical pathways, innovative financing, and RWE. And this really shows how there's been an evolution to go beyond the pill and for private entities, i.e. pharma companies, to focus more on the wider value proposition and not just simply on selling products and services. And there's a question really as to what we can do moving forward and what kind of models we could use to facilitate this evolution. So how can PPPs be used to deal with these challenges and become, as we say, middlemen for innovation and healthcare improvement? Just to define what a PPP is, it's a long-term contract. It's about providing a public asset, and it's about the private sector taking a significant degree of risk, and it's also about linking pay to performance. And I've highlighted these terms because obviously these are big buzz terms and areas of interest in both healthcare and life sciences. Obviously, most healthcare systems operate in one-year budgetary cycles, but there's an interest to adopt preventative, long-term programs which change the treatment model. Equally, as I said, there are services that effectively the private sector could be doing better in some instances, and everybody's interested in linking pay to outcomes. In the past, PPPs have generally been focused on infrastructure, so building hospitals, building labs. It's been pretty one-dimensional, although we have seen some evidence of how this has changed over time. What we're supposing is that given the focus on things like real-world evidence, innovative financing, digital health with wearable devices and, for patients, that actually there are opportunities for healthcare systems, and specifically Greece, that are in economic turmoil, to seize this opportunity and focus PPPs on long-term risk sharing around these different opportunities. Just taking a quick step back and focusing on the more traditional PPP model, this is an ongoing example of a model in Alexandria in Egypt. So 7.4 million patients it's serving. And without going through the details, I just wanted to kind of draw your attention to the services, which are financing, design, construction, furnishing, maintenance, and provision of different facilities. And the point here is that PPPs are able to actually facilitate all these different services, but to change the case mix and to assign public and private entities to these different services in a sense where they're only undertaking a service where they're most able to bear that risk. And obviously then everybody shares in the benefits. I'm not going to say that all PPPs have been successful in the past. The UK, for example, is the home of PPPs, but we have had problems because we've had a lot of success in, as I said, roads and schools, etc., but less so in healthcare, because there's been inadequate due diligence and people haven't really taken the time to set these up properly. So in the long term, the public sector has ended up paying. So in terms of real-world evidence and the opportunity here, most healthcare systems have massive issues with data coding, lack of registries, lack of data quality, and the private sector here has a lot to offer. And as I said, private sector is immensely interested in getting a hold of real-world data and using it to substantiate value. And real-world data itself can obviously be a lot cheaper than going down the road of very expensive clinical trials. most healthcare systems are not really at the stage where they're using RWE as a replacement for RCTs, and that probably won't ever be the case. But in a lot of healthcare systems, we're seeing an interest in using RWE to substantiate value as a supplementary measure for RCT data. And there's a couple of examples here from Janssen and Roche of how they use real-world evidence to substantiate value post-access. Secondly, this is an interesting model which I think could definitely work in Greece. This is taken from Fresno in California, where effectively the Fresno health community, the provider, were having major issues with treating patients with severe asthma. They were coming into the hospital having a major burden on the system, a cost burden on the system because of readmission rates and costs of primary and secondary care. So what they did is, obviously they couldn't afford to pay for adaptations to the model themselves, so they brought in a third party, an endowment fund, to effectively provide the funding up front, change the care model, and provide for patients in their homes, so treatment in their homes, and that in turn reduced pressure on the healthcare system. These patients weren't coming back into hospital, and then the savings over time were then shared effectively between the investors and the provider. So this is a good example of, it's not necessarily a PPP, it's slightly less complex, of where private and public entities have come together for the end good of the patient. And another thing to call out here is, if you look at a lot of these different stages, there's an emphasis on good quality data and subsequent real-world evidence that can be used. And there are obviously positive externalities for this as well for both sides. This is a slightly more complex model that we've developed using Hep C as an example in the UK. So in the UK, and it's probably quite similar in Greece, only about 6% of patients are actually getting hepatitis C products. They're very, very expensive. There's a massive issue around underdiagnosis. So what we've tried to do here is effectively change the way in which treatment and care is delivered to patients. So instead of treating, say, 50 patients for 20 years with some variations, we're treating all the patients in year 0. And then in turn, these patients, because they're provided the vaccine, are not putting a cost burden on the system. And the underlying assumption for this model is that effectively the savings generated by the provider outstrip any premium that would be paid to the outside investor. So in simplistic terms, this is effectively like a loan or a mortgage to the healthcare provider, but if set up properly, it can benefit patients. It links pay to outcomes. It uses real-world evidence, and it's really consistent with prevention, outcomes, and other agendas that we're all focusing on. So just finally, and not to go into too much detail, but could these models work in Greece, and what are the key considerations? One is, I think there's a lot of interest from public and private entities in doing more, but there aren't necessarily enough discussions that happen across the table. We talked a bit about the distrust existing between the pharma industry and providers and payers, and I think there needs to be more of a sit down, and this is happening in other health systems through working groups and specifically focusing on PPPs. Secondly, there needs to be a more detailed understanding of the risks and benefits. So yesterday we heard a bit about program budgeting and marginal analysis. This could go on at a more high level or system level. And really the point here is a lot of PPPs that have failed in places like the UK and France and Germany have been because, as I said, inadequate due diligence and not enough lead time in setting them up. It can generally take 3 to 4 years or more in putting these in place. Third is the consideration of a wider set of metrics. So obviously there's a lot of really good data out there. We could be using things like health-related quality of life measures like the EQ5D. We could be looking at societal benefits if we're making the government take a risk. Obviously a lot of this is complex, but if you can make it work in systems like Greece, then there are benefits to be had, and you're really leading the way in being innovative. The fourth is fix the roof while the sun is still shining, which is effectively saying, be proactive and don't wait for this to happen. And this is something we say a lot to the pharma industry when talking about the data challenge, because, for example, for RWE, because there are still a lot of barriers on the regulatory side, a lot of people are waiting for this to happen, and then in a couple of years we'll be saying, well, we should have been setting up data partnerships with payers and providers, but we haven't. So, I think it's probably a less good example in Greece because the sun is shining all the time generally. But, and then 5 is learn from successes and failures in the UK and other systems indeed. The UK is the center of, the most PPP activity globally has gone on in the UK, so it leads the way there, but there are excellent examples to follow in other healthcare markets. And finally, as I said, a lot of what's going on in Greece is, there are unique characteristics, but the point about resource scarcity and recessions, etc., is consistent with a lot of other healthcare systems as well. So it's about using the transitory state of Greek healthcare as a launch pad for a lot of this, as opposed to everybody sitting in silos and deciding, what we're going to do about the problems. Thanks very much.
Thank you, Mr. Burrows.